The Radiology Review is pleased to offer the second edition of the Board Exam Study Guide, episodes 1 through 131, available for purchase as a book on Amazon or as a digital copy for Kindle. Get your copy today. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRev Podcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
Welcome back to the Radiology Review podcast. And also, welcome to what I am terming Season 2 of the Radiology Review podcast. I have decided to make a conclusion to what I am calling Season 1 of the podcast, as I have recently released the second edition of the Radiology Review Board Exam Study Guide, which comprises study guides for the educational episodes from episode 1 through 131, which is now available for purchase on Amazon. As always, you can also download the study guides for free at my website, theradiologyreview.com, which includes the current episode, by clicking on the study guides page. While you are there, also check out the discount code section, where I often have discounts on things like educational products that may be helpful for you, so check that out. On Season 2 of the Radiology Review podcast, my intention is to continue to provide educational content, as well as some other bonus content from time to time. My intention is to make these episodes slightly more focused, as well as frequently, potentially slightly shorter. So, for example, on a typical Radiology Review podcast episode, I may have an episode focused on something like thoracic trauma. My intention going forward is to be slightly more focused, so instead of an episode comprising a high-level overview of thoracic trauma, perhaps I will dive into something specific, such as pneumothorax, taking a slightly deeper dive in perhaps a slightly shorter episode. And in that vein, the current episode is on ectopic pregnancy. This is certainly an important concept for radiology board exams, and is something I have not covered in detail yet on this podcast. So, without further ado, let's get into the questions and answers for this episode. First question: what is an approximate beta-HCG cutoff below which a normal pregnancy may be non-visualizable on ultrasound? It is commonly taught that with beta-HCG levels below something like 2,000 milli-international units per milliliter, a normal intrauterine pregnancy may be present but not be able to be visualized on ultrasound. For transvaginal ultrasound specifically, a more stringent cutoff, such as something like 1,500 milli-international units per milliliter, has been proposed as a cutoff for which a normal pregnancy should be identifiable. Again, these are general guidelines intended to help you answer board exam style questions, and for clinical practice, please refer to your own institutional and department guidelines. Next question: what is the most common site of implantation in ectopic pregnancy? The answer I am looking for is the fallopian tube, which comprises about 95% of ectopic pregnancies, with the ampullary region being the most common site of implantation, seen in nearly 70% of all ectopic pregnancies. The second most common site of ectopic pregnancy is a so-called cornual, C-O-R-N-U-A-L, ectopic pregnancy, which is also termed an interstitial ectopic pregnancy, in which implantation occurs within the uterine muscular wall about the proximal portion of the fallopian tube. Next, what are classic ultrasound features of an ectopic pregnancy? Let's start with classic ultrasound findings within the uterus in ectopic pregnancy. The uterus should show no intrauterine pregnancy. If an ectopic pregnancy is present, in most cases, caveat on that later in the episode, In most cases, the uterine cavity will be empty. However, in up to 20% of ectopic pregnancies, the uterine cavity will not be empty but may show a pseudogestational sac. More on that later as well. Thickened echogenic endometrium may also be seen without an intrauterine pregnancy. The most specific ultrasound finding of ectopic pregnancy is commonly taught as visualization of a live extrauterine pregnancy with presence of fetal cardiac activity. However, this is not able to be visualized in most cases, especially with early ectopic pregnancies. In terms of the adnexa, an extra-adnexal complex-appearing cystic or mass-like lesion with positive beta-HCG and no intrauterine pregnancy nearly confirms a tubal ectopic pregnancy with greater than 90% certainty by some estimates. A simple appearing adnexal cyst without other adnexal findings denotes some risk of adnexal pregnancy in the setting of elevated beta-HCG and no intrauterine pregnancy, and this could potentially be all that is seen in the adnexal region in a minority of adnexal ectopic pregnancies. Two classic ultrasound signs need to be discussed as well. First, the tubal ring sign, and second, the ring of fire sign. More on those later. In terms of the surrounding pelvis and peritoneal cavity, free pelvic fluid, or more specifically, hemoperitoneum in the rectouterine pouch of Douglas, which is the most dependent portion of the peritoneal cavity, and or in the right subhepatic space, which is also termed Morrison's pouch, increase the likelihood of ectopic pregnancy. A large amount of hemoperitoneum with clinical signs of hemodynamic instability support a ruptured ectopic pregnancy. Next question. What proportion of ectopic pregnancies may not show a visualizable extrauterine gestation on ultrasound? Approximately 15 to 35% of ectopic pregnancies may fail to demonstrate an extrauterine gestation on ultrasound. Note that a visualized extrauterine gestation is commonly considered the most reliable ultrasound finding of ectopic pregnancy. Next question. What is the tubal ring sign? The tubal ring sign is seen as an echogenic ring around an ectopic pregnancy that confirms with high positive predictive value an ectopic pregnancy, typically unruptured. This can be mimicked, however, by a normal corpus luteum, but seeing normal ovarian tissue surrounding the ring supports a corpus luteum rather than the actual tubal ring sign. Next question. What is the ring of fire sign? The ring of fire sign is essentially a very similar thing as the tubal ring sign on color or pulse Doppler imaging, now showing a ring of hypervascularity due to increased vascularity of an ectopic pregnancy. However, this sign can be seen with both a corpus luteum and an ectopic pregnancy. Note, as with many other of the signs described in this episode, absence of color Doppler ring of fire appearance does not exclude ectopic pregnancy in the appropriate clinical setting. Next, given that both can demonstrate a so-called ring of fire appearance on ultrasound, what are other ultrasound features to help differentiate a corpus luteum from an ectopic pregnancy? It is important to remember that an ectopic pregnancy is most commonly located within the fallopian tube, whereas a corpus luteum is located within the ovary. A corpus luteum should therefore move with the ovary, whereas an ectopic pregnancy will move separate from the ovary, and this can be potentially visualized upon applying focused pressure at the site with the ultrasound probe. With an ectopic pregnancy, the surrounding fallopian tube tissue may appear as a ring that is hyperechoic compared to the echogenicity of typical ovarian parenchyma, and this ring of tissue around the ectopic pregnancy is also typically thicker than the relatively thin rim of ovarian tissue that often surrounds a corpus luteum. Next question. What is a so-called pseudogestational sac? A pseudogestational sac is intracavitary fluid within the endometrial canal that can potentially be confused for evidence of an intrauterine gestation in the setting of a positive beta-HCG test. However, this was historically more of a transabdominal ultrasound finding on older ultrasound equipment. Modern equipment, when scanning with transvaginal technique, that shows an intrauterine sac-like fluid collection is reported to be much more likely to be a true gestational sac in comparison to when this finding was originally described using prior generation ultrasound technology. On ultrasound, a pseudogestational sac can sometimes be seen as a centrally located fluid collection in the endometrial cavity versus an eccentric location, which is more typical of a true gestational sac. A pseudogestational sac should also show no evidence of a yolk sac and no other signs of a true gestational sac. A pseudogestational sac often has irregular shape or pointed edges. The intradecidual sac sign is also a potential indicator of early intrauterine pregnancy, which is seen when a gestational sac or intrauterine fluid collection or even an echogenic area is seen within one side of the uterine cavity that shows marked adjacent decidual thickening. However, as with many of the signs associated with intrauterine pregnancy, absence of this sign does not exclude a true intrauterine pregnancy. Last and final question for this episode. What is a so-called heterotopic pregnancy? A heterotopic pregnancy occurs when there is both an intrauterine pregnancy and ectopic pregnancy at the same time. Although rare, there is increased risk of a heterotopic pregnancy with in vitro fertilization. One last piece of important information. Note that serial beta-HCG monitoring is a clinical tool used to differentiate between normal and abnormal pregnancies, especially when there may be diagnostic uncertainty on imaging. Serial beta-HCG monitoring can help one determine when to expectantly follow a pregnancy by comparing a patient's HCG levels to expected curves. Beta-HCG monitoring can in some cases help detect abnormal pregnancies. Beta-HCG levels increase at a slower rate in most ectopic and non-viable pregnancies than in viable intrauterine pregnancies. Additionally, if there is any question regarding the viability of a pregnancy, serial beta-HCG monitoring can also provide critical information by showing whether there is a normal increase in beta-HCG levels following expected curves or whether beta-HCG levels are declining with a pregnancy that is no longer viable. That concludes this episode. I hope this was helpful for many of you. Remember that this topic is for board exam purposes only. Download the free study guide at theradiologyreview.com and keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount codes section. Terms and conditions apply. Limited time offer. Discounts may vary.